In addition to the molecular and genetic markers, right versus left is an important biomarker. It's a anatomic biomarker, if I may call it as such, because it's really relates to sidedness. That tells us whether certain agents work in certain patients or not. So let's take, for example, the right-sided colon. The right-sided colon um, seems to confer resistance, just the sidedness itself, confer resistance to EGFR inhibitors, at least in the first line. So a right-sided colon cancer that is RAS wild type, BRAF wild type, HER2 non-amplified, so all the elements that seem to predict positively for a response to EGFR inhibitors, when you introduce the right-sidedness on the right, these agents show very little activity, if any, on the right side. As such, a patient comes to you with a right-sided tumor. The first line of treatment or for first option would be bevacizumab. Now, when patient progresses through the first line of therapy and goes to the second line, the question is, do you now introduce an EGFR inhibitor? And the answer is, in my viewpoint, no. I think those patients will not respond well to an EGFR, if any, to an EGFR inhibitor. In fact, one of the concerns I have from CLGB 80405 is that there may be actually a negative trend, meaning a detrimental trend for applying EGFR inhibitors in this. And I will go even more controversial. When you go to third line, I will still not introduce at that point an EGFR inhibitor, and understanding that the reverse trial, which was primarily a study that was conducted in Japan, did seem to favor regorafenib given before cetuximab rather than the other sequence, regardless of left versus right. Although, in my clinic, I apply that principle mostly to the right side. Those patients will go through chemobev, regorafenib, then maybe even TAS-102 before an EGFR inhibitor. So EGFR inhibitors will come definitely after regorafenib, and in some patients even perhaps push them beyond TAS-102. That's on the right side. One important aspect of how we do, for the longest time, we've always understood that there is benefit to continue anti-angiogenic agents beyond first line, in fact, from first to second line. With regorafenib hits a little bit of VEGF. It's not primarily a VEGF inhibitor, so I'm not sure about the value of the VEGF inhibition piece itself beyond second line. That said, we have three agents that target VEGF different ways. Bevacizumab targets ligand, ramucirumab, the receptor 2, and then ziv-aflibercept essentially acts as a decoy and captures a lot of, actually all the ligands away from the receptor. Now, is there an advantage to use one versus the other? The answer is absolutely none. Historically, they all seem to perform the same in second line. Ziv-aflibercept is a little bit more toxic. Ramucirumab is more expensive. And frankly, none of those seem to confer a better advantage versus bevacizumab. And therefore, in my practice, if I choose to go with a VEGF inhibitor beyond first line, it's usually bevacizumab, so continuation of bevacizumab. We do not switch to ramucirumab or ziv-aflibercept.